Okay, so welcome all our guests and panelists to this webinar on behalf of Orchid Project and Arrow and the Asia Network to End FGMC. And we thank you for joining us in these challenging times. It goes without saying that we hope that you, your families and friends and colleagues are keeping safe and well as we work together as a global community to overcome the COVID-19 pandemic. You can't see me, but I am here. I'm Ebony Riddell Bamber, Head of Advocacy and Policy at Orchid Project, and I'm going to today act as your moderator for the first Asia Network webinar. Orchid Project is a global NGO with a sole mission to end female genital cutting by 2030. And we've been supporting partners to advocate on the issue of FGMC in Asia for several years. We work globally with partners on advocacy initiatives on FGMC, and we also work at community level to support social norms-based community dialogue. Just a quick note on terminology. I'm going to be using the term female genital mutilation or cutting, FGMC, as a catch-all term to refer to the practice, but we recognize that different terminology is used in different contexts. The main point is that we unify and thus amplify our efforts to end the practice. So firstly, just a quick summary of why we're here before we move on to the really exciting speakers we have for you today. We're here to highlight that FGMC is a practice affecting women and girls across a number of countries in Asia. People may be more aware of the practice in, for example, Indonesia, because we have prevalence data. But less aware about other contexts, such as Sri Lanka. And we'll hear more about both Indonesia and Sri Lanka in detail later on during the webinar. We're here to give a platform to amazing activists and researchers who are working within the Asian context and give them an opportunity to share their insights and their research into the practice. We're also here today to share what Asian-based activists and researchers think an Asia network to end the FGMC could achieve to enhance our shared vision of a world free from FGMC. So before we move on, and I hand over to a colleague from Arrow to do the welcome, just some quick housekeeping so that we all know how we're going to run the webinar. We are going to be recording the webinar so that those who are unable to join us at this time can also hear the insights and have access to the discussion. And we'll be sharing this by email afterwards. Please, I ask you to keep your microphones muted and also your webcams off to improve and optimize bandwidth and accessibility for all. So you're not going to see many of us on video just so that we can make sure that we optimize bandwidth. There will be opportunities to ask questions for our panelists at the end. So please use the chat feature to type your questions as we go. We really like to hear your questions and pose them to our panelists. A key aim of this webinar is to really optimize and ensure greater prioritization of the issue of how female genital mutilation and cutting is affecting women and girls across Asia. So please be active on social media, use the hashtag, which you can see hopefully in front of you on the screen, which is EndFGMC Asia, hashtag EndFGMC Asia. And also if you can tag at Orchid Project, at Arrow as well, that would be great. The resources will be shared from this webinar will be shared in a follow-up email for everyone who's registered. And just a quick reminder to our wonderful speakers, if you could keep to the allocated time as much as possible, and we'll give you a time prompt just so that you know you have a couple of minutes before the end of your time slot. We just want to make sure everyone has equal time to share their insights and also that we have time for questions. So you can see the agenda in front of you and the hashtag, so please use it. The sort of overview is that we have an hour of presentations and then we'll have 30 minutes for Q&A at the end. We have representatives from Indonesia, as I said, Malaysia, Sri Lanka, and input from Islamic Relief Canada and Orchid Project. So it gives me great pleasure to introduce our first speaker, who's going to give us a welcome, and that is Sivanananthi, who is Executive Director of ARROW. ARROW are our co-partner on this initiative, and Siva is going to formally welcome you to the first Asia Network webinar. So a quick biographical note about Siva before I do that. So Siva is ED, as I said, of the Asian Pacific Resource and Research Center for Women, ARROW, which is a regional partnership organization working across 15 priority countries in Asia Pacific, with regional organizations and networks across the global south. So over to you, Siva.
Thanks, Ebony, and it's great to be with everyone today. Could I have the first slide, please? Yeah, so FGMC is a global issue that requires a global response, right? And girls are and women are affected on every continent except the Antarctica. Each year, at least 4.1 million girls are cut globally, which will rise to 4.6 million girls by 2030 due to population growth. Unknown to many, over 1 million of these girls will be in Asia. So one of the reasons we started the End FGMC Asia network was basically to be able to shed light and break the stereotype that FGMC is just an African issue. Next slide, please. Yeah, so ARROW and Orchid started working together from the beginning of 2019 to co-nurture this really critical network, the Asian Network to End FGMC, and it's particularly aimed to support grassroots organizations. The informal launch of the network was held at Women Deliver in June 2019, where Orchid was hosting, along with other networks, this amazing event, which I remember. And the launch itself saw great interest from the global community towards the issue, as most did not see FGC occurring in the region, and it dismantled the idea that FGMC is an African issue. In many Asian contexts, FGMC, unlike what is seen in Africa, is closely interlinked and framed as an issue of religious obligation. And of course, as a means of curbing sexual desire impulses in women and of course, limiting the sexuality of women. To create change, it is really essential to build a broad-based network of researchers, activists, and organizations so that we are able together to create this paradigm change that is necessary in our societies. Next slide, please. Yeah, so in 2019, FGMC also received global attention through international advocacy spaces such as ICPD 25, which was held in Nairobi, Kenya. And at that time, the president of Kenya himself had committed actively towards ending FGMC in the country. Within the Nairobi commitments, countries were actually asked again to recommit to zero SGBV. And FGMC is seen as one form of violence against and cultural practice violence against women and girls. So the network aims to create a platform to provide support and capacity building to activists and organizations working on the issue, gather data and evidence on prevalence, and to tackle the medicalization of FGMC in many of our countries, and also to urge governments to report on the SDG indicator 5.32 as related to FGMC. And I believe next slide is yeah. So as we know, COVID-19 has kind of gathered the attention both at the global stage as well as the national stage, right? And we have also, had consulted many of our partners, and COVID-19 has definitely limited organizations' ability to do the regular advocacy and outreach work. Physical meetings, which are sometimes essential for trust building at the community level, have to be postponed due to COVID-19. Advocacy work has also slowed down due to the lack of access to policymakers and decision makers around this time. A lot of regional and international advocacy has been halted, or the events have been postponed or will be carried out in an online manner. We saw that with CSW this year, which was held as a one-day event and only limited to New York-based missions and organizations. So FGMC, along with a plethora of rights issues, have also become less of a priority with COVID-19 and the urgent issues surrounding it becoming the main priority of governments. So the possible impact that COVID lockdowns could have on plans to cut girls within the community, from what we have heard from some of our partners and organizations, is either that those who are set on doing it will merely postpone their plans by a few months. In some communities, the practice will further continue, but further shrouded in secrecy because, during the lockdown period, they may not have access out to outside communities. So they would be between the family and the traditional practitioners. Or perhaps a section of the community may use this opportunity to rethink FGMC entirely. So there is possibly a window for us to actually continue our work. Yeah. So in that, we just want to make sure that we as governments need to hold our government, we as civil society organizations need to continue watching what is happening on the ground to generate evidence and data, and to keep our governments accountable to the commitments that they have made, even within the time of a pandemic. So thank you.
Thanks very much, Siva. Really useful insights and great to have a bit more of a summary about how we got to this point. So our second speaker, just to move on quickly so that we can maximize the time, is an amazing pioneering campaigner on FGMC in Indonesia, Ibu Atas. Ibu Atas has over 20 years of research experience in gender and reproductive health and rights issues, with a focus on the life of Muslim women and girls. She was elected as vice chairperson of the Indonesian Planned Parenthood Association in 2010, and has held a series of elected governance positions in the International Planned Parenthood Foundation since 2012. She's currently coordinating head for Article 12, which covers women's health, including child health, at CEDAW Working Group Initiative in Indonesia, where she leads work streams on FGMC. So please give a warm welcome to Ibu Atas.
Hello, hello everybody. Hello, hello, hello. Good afternoon. Hello.
Good afternoon.
Good afternoon. Good afternoon, everybody. Hello.
We can hear you, Ibu Atas. Carry on.
Okay. Thank you. Good afternoon. First of all, I will start about the scale of FGMC, or we call it female genital mutilation in Indonesia. Maybe before we do that, I will start how actually started with us as women activists. We started at the university. At that time, in the 90s, many of my friends went to the Beijing conference, 1995, and that was the first time that they came back and asking all of us who are working at the university to do a research, because the Beijing document, especially about the girl child, it was stated that eliminate negative cultural attitude and practices against girls. So who actually started in Indonesia with all those women activists who were at the university? So one of them is myself at the time as a researcher. And so we started to see in our own environment. So, and since we all the activists coming from several provinces, we became aware that all of us were undergone female circumcision. So why we don't look at that issue? So at the end of the 90s, we started with a small funding from the Population Council, and then we discovered that, oh, it is really a big issue. So in I thought that it was in year 2000, we finished with the study in 9 provinces. It was, of course, a small study, but it started from the university in the 9 provinces. And we saw that it is not a small issue, because at the time, every year, 3 million babies were born. So half of them were girl child. So we come to the funding agency to do the research. And so after the research, we are bringing to the Ministry of Health. And finally, we are very happy that those 2 health officers, female, both of them, just went also to the ICPD in Cairo in 1994. So they understand that female genital mutilation becomes one type of violence against women from the perspective of ICPD. So finally, in 2005, we succeeded to organize a series of workshops in collaboration with the Directorate General of the Public Health, Ministry of Health. So that was in 2005. We organized a serial because Indonesia has several ministries. The Ministry of Health would like to have support from the religious ministry. We have a special Ministry of Religious Affairs and also Minister of Women Empowerment. So we succeeded in the coming 3 years to organize all those activities, to getting aware that the female genital cutting is actually a serious problem. So they are becoming aware, and we are succeeded. Especially what first it succeeded is that we collaborate with the religious leaders who are against female genital cutting. So, and of course, after we collaborate with them, of course, we see that back to the scale of FGM, we are succeeded in getting the National Statistic Bureau to know how far the female genital cutting is spread over the country. So in 2013, we are very happy that a big study, and you see here, this is the National Statistical Bureau showing that more than half of the baby girls undergone female genital cutting. So this is our first thing what we did. That is the research in 2013, and it is from the government side. So the recognition is there that this is a problem. We should take those people accountable. So next slide. Yes, this was in 2005, and in 2006 we had at the time a female Minister of Health, and so she has the courage to issue decree on the prohibition of this female circumcision by all health providers, because we see from many research that who are the one who spread the female genital cutting was the midwife. So we see that the medicalization of this female genital cutting. And as you know, almost 60% of women in Indonesia delivered and helped by midwives. So, and back to the history, from many written historical sources, it is known that during the Dutch occupation, that was until 1945, only some specific communities practiced female genital cutting, and it was morally just in Java. And we are happy that in 2005, even the high officer from the Ministry of Religious Affairs were saying that when he was posted for 20 years, even in Borneo, there were no baby girl got circumcised. In the 80s, can you imagine? In the 80s, he was for 20 years. But after, in the 90s, the midwives who are coming from Java, most of them coming from Java, perform the female genital cutting to Borneo and to other big island. So then we see that who spread the female genital cutting is those midwives. And but denial is still there. So, and after this ministry decree of the Minister of Health, some religious conservative leaders were so against the Ministry of Health and asking to stop with the decree. And later, another Ministry of Health, because unfortunately, the first female Minister of Health passed away, and so the next female Minister of Health enacted another decree saying that, okay, it's okay, but using a needle. And so we as women activists were so angry at the time, why you are going back to medicalize this practice by now using just a small needle, because it was said that still they need the needle to show that the cutting is happened by showing some blood. Can you imagine? So we were very angry because our aim is don't touch our genitals. So next. So yes. So and of course we should be very close with the midwives organization, because we have at the time 370,000 registered midwives, and those are the ones who perform it. And so, of course, because Indonesia is so big with 34 provinces in the country, it's so difficult. Of course, maybe half of the midwives are also rejected to perform the female genital cutting, but still, many of them, especially in the region, are still doing. While at the Midwives Academy, never, the Indonesian Midwives Academy started already 60 years ago, and never they had in the curriculum to show how to do a female genital cutting. Yeah, so it is not in the curriculum. So that's why there are so many types of FGM. Okay, and our recommendation is ending the female genital cutting by, of course, we should working with the moderate religious leaders And also, of course, with the doctors. It is many gynecologists were working with us to convince, especially male, because the male gynecologists coming together with us do the advocacy work and showing that there is no need to do any circumcision, and also especially with the moderate Islamic leaders, that to convince all the mothers, parents, and especially, of course, also the grandparents, because they are so afraid that if they are not perform female genital cutting, they are not Muslim enough, and so the parents will not go to heaven, because it is actually the obligation of the parents and the grandparents that for a girl to be a genuine Muslim, they should be circumcised. So that's why this is our advocacy work. It is really a very broad advocacy work, but we are so happy that UNFPA Indonesia, especially for UNFPA Jakarta, that they are always consistently since 2005 supporting our work to stop female genital mutilation. And the second question, what is needed to end the practice in Indonesia, and how can the international community help? I think it's very important that in our region, especially East and Asia, should we have a network, because everybody knows that a network at the regional level should be there, since we all know that the conservative Muslim intensifying their thinking. People see really now the last 5-6 weeks that with the big coming together in all of our provinces, those conservative religious leaders coming together from our region. They are always coming, just they finish a big meeting with the ASEAN, that is just the 10 countries, with all the conservative religious coming in Indonesia, in some provinces, and they are coming back, and because it is all on the TV, so we see them coming home, and everybody was infected. Many people was infected by the COVID. Because so that's first. I'm so happy. I am welcoming the network, because as you know, I'm so sorry. I already told Ero that please, Malaysia, I'm so in front of my own experience. I was in one of the department in Jakarta, just in the lift. I was with 3 other people who just came from Penang, from one of the hospital there, and they are promoting, if you know somebody who would like the daughter be circumcised, please, you can come to this hospital in Penang. Can you imagine? And it is not in Indonesia alone, that not just only the midwives, no, performing still performing the female circumcision, but also now the GPs. The GPs. From my own study, a small study in Jakarta, some hospitals perform female circumcision by GPs. So I think, thank you. And we are very happy and supporting this network. Thank you.
Ibu Atas, thank you so much for an amazing presentation. Such insightful information you've said about the sort of journey from the Beijing conference to enabling there to be household survey data on FGMC in Indonesia, to the practice being spread by midwives. So much in your presentation was fascinating, and we've all learned so much from you. Thank you so much for sharing, and we look forward to working with you further on the network as it develops. So moving on to the next presentation, and we want to just quickly share some of the findings from the consultation that Arrow and Orchid Project conducted between August and December of last year. The aim of the consultation was to enable us to connect with and learn from the work and insights of organisations, activists and researchers, such as those who are speaking in this webinar, to get their insights into their work on FGMC and also related issues such as gender-based violence and sexual reproductive health and rights issues. So I'm delighted to hand over to my Orchid Project colleague, Lo Riches, who is our Advocacy and Policy Officer, with whom I co-authored the consultation report. And Lo's going to take us through some brief highlights from the consultation. So just a quick thank you to all those that responded to the consultation and that have supported the network so far. So over to you, Lo.
Thanks, Ebony. And I just also want to reiterate my thanks to everyone who was involved in this consultation, many of which I know are joining us on this webinar. We really couldn't have done this without you, and we hope that this consultation report is helpful as we start building this network with you all. So I'm going to start right in just with a brief touch on the methodology and how we went about the study. So we opted for a methodology that would allow us to gain both depth and breadth of response whilst being as inclusive as possible in order to build relationships, legitimacy and buy-in with activists and grassroots organisations across the Asia region. Over the course of about 6 months, we conducted over 22 semi-structured interviews with activists, researchers and organisations across 8 identified priority countries in Asia. And we further received 52 responses to our online consultation from 13 countries in Asia. Of those that took part in the consultation, you can see in the first chart here a breakdown of stakeholder type. So 25% of respondents were individual activists, whilst 42% identified as either civil society organisations or community-based organisations. Interestingly, 19% of respondents were journalists. Equally, it was important to open up the consultation not only to those who are currently able to work on FGM/C, but also to those working on related or similar issues that might take up the issue if they were given capacity. So we just wanted to note that 25% of the respondents in the consultation had actually never worked on FGMC. And just to point out that we did ask participants what types of activities they were carrying out, and the majority of respondents are carrying out advocacy activities, very closely followed by those carrying out community dialogues and thirdly research activities. Next slide. So participants were asked to identify what they perceived as the key driving factor or factors behind FGM/C in their local contexts. As you can see from the left-hand graph, a majority of respondents identified religion as the main driver, followed by social norms and gender inequality or gender norms. We then asked them what they felt was needed to end the practice of FGM/C in their local context. Here, a majority on the graph on the right-hand side identified the need for greater political will, legislation and policy, alongside increased awareness-raising activities. You can see that working with practicing communities was also identified as highly important. Next slide. So we asked participants who are currently or have a history of working on FGM/C about their capacity building needs in order to guide the priorities of the network to respond to the critical needs identified by those working on the ground. You can see that the largest majority, so 27 participants or 30% of responses, identified a need for greater research and evidence building on the practice across Asia. 23 participants or 26% identified a need for capacity building on advocacy, and 18 participants or 20% pointed to a lack of access to funding as an area for greater support to work on FGM/C in the region. For those participants who did not have experience of working on FGM/C, 29% identified a lack of access to funding as the primary reason for this, which was swiftly followed by a lack of information, evidence, and research into the practice across Asia, which is perhaps unsurprising. Next slide. So throughout the consultation, we received exceptional and courageous stories from brave activists operating in very challenging contexts. We have assured their anonymity to protect their participation in the network and its activities, as well as their own activism, livelihoods, and community relationships. So there were a number of recurring security challenges that were raised across the region in relation to activism on FGM/C. These included threats to economic security or social standing, social sanctions, which included excommunication being practiced by the communities, social media trolling and abuse, restrictions on freedom of movement, and a general feeling of public backlash against activists carried out by either the media or public opinion more broadly. So those are some of the examples that we came across. Next slide. So participants were asked to rank their priorities of preferences, their priorities in order of preference, for network activities in order to give the network a broad sense of direction at this stage. So the first preference that was identified, you can see, was FGM/C and religion as a thematic priority. And that was 27% of responses. The second preference, so this is the pink bar that you can see on the graph, there was quite a clear preference out of those second preferences. So the majority of people on the second preference option opted for work on changing social norms. So 35% of respondents put that as their second preference. And then when asked for their third preferences, 25% opted for access to services for survivors. We've chosen to group the number of first, second and third preference rates for each theme in this bar graph to give greater nuance. So there are a number of different ways that we can look at priority preferences. So that's sort of looking at the preferences sort of individually on first, second and third. But you can see that when we group them together, the total number of votes given to each themes, changing social norms and FGM/C and religion, have considerable support on the whole. So next slide. So on the basis of the consultation, we've put forward in the report a series of recommendations to both governments across the Asia region and the international community, with an emphasis on donors. There's a longer list of recommendations and conclusions in the reports, but we're just sort of highlighting a few in this webinar to give you a taste. So firstly, to Asian governments, we ask that you criminalise all forms of FGM/C, including when carried out by a medical professional. We're asking Asian governments to carry out representative household surveys and research into FGM/C and commit to national reporting on SDG 5.3.2. We're asking that they develop evidence-based national action plans with national budget lines and a commitment to awareness raising and community programming within that response. And we're asking that they consult and engage religious leaders, scholars and institutions to issue fatwas against all forms of FGM/C. To donors in the international community, we ask that you significantly scale up funding, capacity building and networking support, significantly scale up investment in representative survey data collection and research on FGM/C across Asia, and to encourage Asian governments to enact legislation, national action plans and budget lines to end FGM/C. Finally, we're calling for greater support to rights-based, non-judgmental, community-based programming that can address harmful and social and gender norms within the Asia region. So with that, I'm going to hand over back to Ebony, and I really hope that many of you will get a chance to read the report in full at a later stage. Thank you.
Thanks, Lo, for that great presentation, and I hope that has shared some insights into what we've heard from various activists, researchers and organisations working across the region. Lots of really valuable insights from them and information about how a network could strengthen and enhance our shared goal to end FGMC. So on to our next speaker. So please allow me to introduce Professor Dato Dr. Abdul Rashid Khan, who is a prominent researcher on FGMC across the Asian continent. Dr. Rashid is a medical doctor and is currently the professor and head of Department of Public Health Medicine at the Malaysia campus of the Royal College of Surgeons in Ireland and University College Dublin. He's been studying FGMC among the Malay Muslim community since 2009 and is now conducting research on the practice in Vietnam, Cambodia, Thailand, and also Indonesia. So you're going to hear about some context that perhaps that you're less aware of in which FGMC is being carried out. So we're now going to connect to Dr. Rashid via video share. So if you just bear with us a moment because he'd like to speak to us live. So just give us a moment to sort that out.
Thank you for the kind introduction. I've been doing a bit of research on female genital cutting here in the northern part of Malaysia, Peninsular Malaysia to be specific. So I'll share with you some of the findings that I have. Well, actually there's not much research that's been done here in Peninsular Malaysia specifically. I think there's only about a handful of research that's been conducted. So I'll share with you some of it. And just to be clear that most of this research, if not all, have been conducted among the Malay Muslim community are mostly Sunni Muslims who are followers of the Shafi'i school of jurisprudence. Now, this is an important information because whatever programs that we intend to do is related to this particular group of people. Now, from what we know, more than 90% of the Malay Muslim women have undergone female genital cutting. Now, the latest study that we did last year, me and my colleague from Japan, Professor Yufu Iguchi from Ritsumeikan Asia Pacific University, we found that 99% of the Malay Muslim community in the villages had undergone female genital cutting. Now, what is interesting about it is that a very big majority, more than 90% of them, consider that it is mandatory in religion. And as far as they're concerned, all the sects in the Muslim sects do it. And they all do the same form of genital cutting. So they obviously have not heard about female genital mutilation and what is being done in Africa. So, and as far as they're concerned, is that it is legal in the country. I'll come to that a bit later. Now, previously, when we analyzed the data of the older population, we found that a lot of them were done by the traditional midwives, who we call bidan in this country. Some call them mak bidan, some we call them tok bidan. These are all affectionate names for mother and grandmother. These bidans were the ones who were doing it. But in the younger generation, those who are 30 years old and below, we found that a lot of them have gone through the cutting by doctors in clinics. And when we asked them who would they prefer to be done, and a lot of them preferred that doctors should do it. In the elder population, they prefer, of course, the bidans, but their main complaint is that bidans don't do anymore. Now, among these bidans who were still practicing, were very few left. a lot of those who were interviewed were already retired. They were not doing it anymore. And those who did, those who still remember what they were doing, interestingly, it was quite interesting what we found out, that they actually only nick, and most of them prick the skin overlying the clitoris. And there was no major trauma. We were lucky to witness a few. There were no major trauma. But for some reason, there's this thing about a drop of blood. And how much is this drop of blood? They equate it to the size of a mosquito. So it's basically trying to tell us that it is just a very, very small amount. They say without that drop of blood, the whole practice is considered not successful. Now, a lot of them actually have retired. They're in their 80s, 70s, some of them still in the 60s who were practicing. We were lucky to be able to interview them. We met them. And they're generally in the rural areas, and they use razor blades, pen knives, and a lot of them prefer razor blades. When we asked them why, the reason that was given was because they were worried of infection. I found that a bit very interesting, that they understand the idea of infection. The younger population, of course, the community preferred that doctors should do it. So when you think about doctors, so last year, the year before, we started this study on doctors. When I say we, I have to give credit to my colleague from Japan, Professor Yufu. Both of us involved in this study. We found that 20% of the Muslim doctors practiced female genital cutting by their own admission. However, from data that we have from the community, about 40% of them claim that they had undergone FGC from doctors. So probably a number of doctors did not admit that they were practicing it, because there's a bit of a gray area. And what do I mean by a gray area is that the Malaysian Medical Council have not actually outright said that they cannot practice FGC. Nothing is there in black and white at the moment. Same thing where legal law is concerned. There's nothing that is clearly mentioned that they cannot practice it. Now, a lot of reference has been given to a fatwa that has been given in 2009, I stand corrected, by the National Fatwa Council, that it is wajib, meaning that it is mandatory in Islam. But fatwas are not enforceable in this country. And religion, interestingly, it doesn't fall under the federal jurisdiction, it falls under the state jurisdiction. So there's a bit of controversy there, a lot of gray area where people are unsure. So when we did interview doctors, they say that, as far as they're concerned, they're not doing anything wrong, those who are practicing, and that they would like to continue with the practice. And we did manage to see a few. Generally, what is being done is that they use scalpel, needles, and occasionally scissors. Everything is done in a sterile condition. Now, let's go back to what the Mak Bidans were doing. The Mak Bidans were doing type 4 FGC. But what we found very interesting was, in this study, there were quite a number of doctors who were doing type 1, where they were actually cutting part of the clitoris, which was never traditionally practiced by the Mak Bidans or the Bidans that we interviewed. And we're talking about these Bidans who we interviewed who were practicing for 40, 50 years. And it was completely unheard of where they would touch the clitoris. we never came across even a single bidan who did that. Unfortunately, now the doctors are doing it. Well, there's a bit of logic to what they're trying to, well, their logic is that what is the point of nicking or just pricking the skin over the clitoris? So their logic is that it needs to be, part of the clitoris needs to be cut. Another reason for it could be that they use local anesthesia, and that would numb the area so the baby or the child would not struggle as much. So they tend to cut a bit more. So that's the drawback of using local anesthesia. Now, we go back to the reason why they do it. So when we ask the doctors, main reason, again, religion. Again, religion. It goes back to religion. So the community, when we interviewed them, again, the main reason was given religion. Interestingly, the bidans, however, said that it is not mandatory. It is just recommended. So either do it or leave it. It doesn't make a difference. So we found that fascinating that the bidans actually had a different opinion than the community and the doctors. So we went back and interviewed the mufti of each state. Is the head of religious, would you say, department, who advises the sultan of the state. So one of the, I would say, a fairly conservative mufti, he was very clear to say, no, it is not. It's just a recommended action. So, and whereas the other one was a bit more blunt, he was very clearly saying that, no, this is wrong. This practice is not needed anymore, and we should stop it. So while in that conversation, I actually asked him, if this is what you think, if this is what I'm telling you the community is doing, do you not think that maybe you should inform the community that this is not a mandatory practice? Now, interestingly, he was keen, but again, he says, where is the evidence, that you say that the community? So doing one or two or handful of research is not enough. We need bigger data to be able to convince them. So that was a good loophole. I thought that would be very effective in a step forward in trying to at least reduce or stop the practice among this group of people. Now, the other thing is about the Malaysian Medical Council and where the Malaysian Medical Council stand. That's very confusing. The doctors are not sure. We are unable to find anywhere that states that this practice should stop or doctors should not practice this. There's nothing clearly written. So that is another area that needs to be looked at. The future, well, more than 99.3% of the community that we interviewed, the Malay Muslim community, said that they will continue doing it. They have got no intention of stopping it. They say they see no reasons to stop it. And more than about 80% of the doctors that we interviewed said, yes, they would like to continue. Even those that don't practice, they think, one is that some of them think that they are doing the community a favor. They consider it as a harm reduction because they feel that if this practice is stopped, they're worried that parents will start taking them back to these bidans, and they're worried about infections, HIV, hepatitis B, and so on and so forth. So they consider it as a harm reduction. But a very big majority say that is because they believe it's, they have the same beliefs as a community. So they think there's a religious ground for the practice. And whereas the others say, well, listen, it's so minimal, it makes no difference. So they feel that it's such a minimal practice that they don't see a reason why they should stop. Although I must say that most of those that interviewed, if I put it to them, if the Malaysian Medical Council says that you should not do it, what would you do? And almost all, I think all, I would dare say, said that you'll stop doing it. You'll stop doing it. So there is a light at the end of the tunnel, I would like to say. where future is concerned. But it's going to take a lot more research, a lot more data to convince the Malaysian Medical Council, the religious bodies, the government bodies, and trying to tell them that, you know, this is what we have, this is what's going on in the community. There's a misunderstanding, misconception of what is the requirement in religion and whatnot. So we have still a long way to go where Malaysia is concerned. That is why I think when I mentioned to earlier when we had this informal meeting, and I said that we need more research, and to do research we need more grants, we need more collaborations. We are still very at a very early stage. Okay, I'll quickly touch on what we're doing now. So what we're doing now is we worked our way backwards. Again, as I said, that Sunni Muslims and Shafi'i school of jurisprudence are the ones who are doing it. So we know that we have studies in Thailand that have done it. We know that Indonesia has got very good data. So we thought about Vietnam and Cambodia, where there is quite a substantial Muslim population there. So we did our initial groundwork, and we found that the communities there are doing it as well. So we started last year, late last year, in December, in Vietnam and Cambodia, a study to see that the practice of FGC in the Muslim community there. We know that they are doing it, but unfortunately, because of this COVID pandemic, we were supposed to go back a few times this year, so it's on hold at the moment. So we hope to continue with that. It's quite a big study, hopefully. It involves Cambodia, Vietnam, Thailand, Malaysia, Indonesia, using the same questionnaire. Hopefully we're going to get the same data that will be comparable within this region. Let me see if there's anything else I missed out. Okay, I think I'll stop. I've got my 10 minutes up. Thank you. Thank you very much.
Thanks so much, Dr. Rashid. Just so interesting to hear about your latest research, and obviously we look forward to hearing more about Vietnam and Cambodia when that can actually start. It was really fascinating in particular to hear around the shift from potentially type 4 to type 1, as you describe it, through the medicalization of the practice in Malaysia. So lots of work for us to do in relation to that. And interesting, you've identified the Malaysian Medical Council as a real advocacy target for us. So thank you very much. So back to the presentations, and we're really interested and excited to hear about the context in Sri Lanka. So we now have input from two extraordinary activists and advocates who've carried out the first study of FGMC in Sri Lanka. So please welcome Zainab Ibrahim and Ermiza Tegal. Just a quick bio note about both of them. So Zainab Ibrahim is a feminist activist and researcher based in Sri Lanka with a primary focus on issues of gender equality and women's rights. Her most recent work includes co-creating a platform to document violence against women, girls, and trans people in technology-related spaces in Sri Lanka, research and activism on the issue of FGMC, and through her work with Chrysalis, she's co-leading a global team on the prevention of gender-based violence on behalf of Care International. And Ermiza Tegal is an attorney at law practicing before the Supreme Court of Sri Lanka, where she leads an all-female legal chambers and represents victims and survivors of torture and domestic violence. In recent years, she's been involved in advocacy on reform of Muslim personal law, human rights and counterterrorism, law reform to prevent domestic violence, research and advocacy on FGC, and also exclusion relating to land rights. So it gives me great pleasure to hand over to Zainab and Ermiza to take us through their presentation.
Thanks so much, Ebony, and thank you, Arrow and the Orchid Project, for this opportunity to share some of the work and experiences from Sri Lanka. My colleague Ermiza and I will share this brief presentation, and I will begin by telling you what we know of the practice in Sri Lanka so far. There are no formal quantitative studies of FGMC in Sri Lanka to date, so there are no numbers of prevalence. There are no clinical studies, and there is limited published information in general. One of the most recent actually is a study that you see on the screen. And if any of you are interested in some of the work that has happened in Sri Lanka, I would also urge you to read it. What we do know is that FGMC is widespread among the Muslim community of Sri Lanka, though there are variations in practice based on age at which it's carried out and by religious sect. For Bora Muslim women, for example, it takes place at the age of 7 years. So for some girls, there is actually a memory of what happens, and therefore there are psychosocial implications as well. For some other Muslim sects, it is done when the girl child is 9, 15, or at 40 days. There are also some sects that do not practice this, the Mayman community in Sri Lanka being one example. In the Bora community, FGMC is carried out by medical doctors, although it is not a formally medicalized practice here. And among other Muslim sects, it's carried out by traditional practitioners, usually women who come to shave the baby's head or clip nails at certain times. There is also a fatwa or a religious decree issued by a leading religious body here, which recommends the practice. And something that Ermiza and I found in the course of our exploration, our brief study, was that the reasoning for this practice among women we spoke to was actually not consistent, and the reasons varied rather widely. The most prevalent forms in Sri Lanka, from what we know, are type 1 and type 4 of the WHO classification. That is partial or total removal of the clitoris and or the clitoral hood, and all other medically unnecessary procedures like nicking, pricking, piercing, and cauterization of the female genitalia. Reports of lasting harm, right, is available, has also varied widely, from continued pain on sexual intercourse due to nerves being exposed to no lasting impact at all. Until a few years ago, it was widely believed that this was not an issue in Sri Lanka, and that it did not take place. And this was also the view among policymakers, medical practitioners, and it's only recently that public officials and activists have begun to engage more significantly on challenging this practice. Could you go to the next slide, please? So most of what we know so far builds on the collective work and activism of the past 4 to 5 years. It has been led primarily by women from affected communities, some of whom are survivors themselves. And this activism has taken place mostly under the radar for reasons that I think Ermiza will also talk about. The time was ripe in a way for this activism in Sri Lanka because locally there were efforts to reform the Muslim Marriage and Divorce Act, the Muslim personal laws. Regionally, there was a momentum on this issue, particularly in India. There were also court cases in Australia and in the US at that time that were grappling with the issue of FGM. So this kind of so local efforts also went in parallel with a lot of these regional and global efforts that were taking place at the time. So through these local efforts, testimonials were collected from women and submissions were made to relevant state and non-state institutions, such as the Human Rights Commission of Sri Lanka, the Parliamentary Women's Caucus, the National Child Protection Authority, UN bodies, among others. And all of this activism, together with supportive public health officials, resulted in a circular being issued in 2018 by the Ministry of Health, asking doctors in the public health system not to engage in this practice. What women have expected as support has varied. Some women have asked for criminalization, for a complete ban on the practice, also for the engagement with community leaders to stop it altogether. There have been requests for more information and awareness, particularly on what the religious basis for the practice is. There have also been calls for medicalization and training of traditional practitioners to carry it out safely, to some women saying that they don't need any support at all because they don't see this as a problem. I'm going to close this section. I'll stop my presentation by saying that the narrative on this issue is also taking place in a context of limited or restricted space in Sri Lanka. Taboo plays a large part in how the practice is spoken about, or actually not spoken about, and also how it is understood. So the conversations that Ermiza and I had with women in the recent study we did were among the first that some women were having on the subject. They said they did not even speak about this even in their social or family circles. So the spaces available to women to articulate and explore this issue is also limited, even in the medical sphere, where conversations primarily focus on women's reproductive health. Although I must say that the health sector is still seen by women as a trusted place and therefore can be a trusted entry point. So this is an evolving conversation still, one that has a bearing on the rights of children and on women's sexual health and rights and her rights to bodily integrity. And that framing, or the lack of that framing in turn, has a bearing on the types of support and services that are asked for and also made available. I'll stop here and hand this over now to Ermiza, who will talk to you about the context of FGC activism in Sri Lanka. Thank you very much.
Thank you, Zainab. Hello, everyone. Continuing from Zainab, it has been really important for both Zainab and myself to think about the context in which these conversations are taking place. In Sri Lanka, this has meant, firstly, a context of concerns for personal security. Women have concerns about displeasure from family members, displeasure from community members, possible excommunication. Even questioning runs the risk of being labeled un-Islamic or not having a strong enough faith. This sits again then within a broad and persistent context of not having a culture of openness about violence against women, sexual and reproductive health rights, sexual desire. Women expressed embarrassment when talking about this taboo subject. Some spoke of domestic violence as if it was a normal phenomenon, and also raised difficulties about airing concerns about family planning, even within their families. This means that women did not have access to language and information to talk about these issues. This then again sat within another context of intolerance, which takes the form of violence and racist speech against the Muslim communities in Sri Lanka. And I use the word communities purposefully because there are so many different sects and groupings of Muslims in Sri Lanka. And women were very conscious of this context of intolerance when they spoke to us. Their speech and their actions are then again also judged as representatives of their communities. And they therefore guard themselves when they do talk about this issue. This context of intolerance is also experienced by individuals in the health sector and policymakers who spoke of strong challenge of them taking up this issue and difficulties of extending safe spaces to women, concerns of being accused of interfering in a minority rights concern, and their concern that their actions may be perceived as an added attack against the community. Appreciation for these different layers of context is so important. Working on understanding FGC in the Sri Lankan context required us to have an approach that was non-judgmental, that was a personal security conscious, and at the same time providing a space that acknowledges the personal desire to express identity that women had. I think for Zainab and myself, our identity as Muslim women also gave us that opportunity of access to Muslim women. Can I move on to the next? Sorry, this is the slide. In terms of expectations from a regional network, we think it's important to have a vibrant regional space of publications, events, discussions, to which local advocacy can then link to. This will support and amplify local perspectives and women's voices. And hopefully this will also support development of shareable resources which can be translated. We do draw strength from comparative experiences. We must acknowledge that women engage on this topic using different lenses, something that we also draw on the Musawa framework on, and say that we need to look at this issue in terms of comparative lived realities, medical perspectives, religious perspectives, and different rights perspectives, whether it's child's rights or women's right to bodily autonomy. This also strengthens the hand of policymakers and health professionals. So we understand that women may choose to talk about this issue in terms of lived realities, or they would prefer to talk about it in terms of a medical issue, or they would prefer to talk about it in terms of a religious perspective, or they would adopt the rights language to speak about it. And therefore there needs to be information in all of these areas. And lastly, we see strong interest for community dialogue and community approaches on this topic. And therefore, the need to then strengthen women and women's spaces to engage in conversations is a key step that we see that we need in moving forward. I'm going to end on that note. So thank you everyone from Zainab and myself for your interest and your patience. We look forward to your questions, and over to you, Ebony.
Thank you so much, Ermiza and Zainab. You were right on time, so you get extra brownie points for exactly sticking to the 10 minutes. Great to hear all of the insights. And obviously you've done a lot of work to think through how to approach this issue in the Sri Lanka context. And I think, you know, the culture of intolerance that you mentioned is something that we need to be mindful of throughout the work of the Asia Network. So thank you for sharing your insights and your research. So we encourage everyone to have a look at the research in more detail. So we're sort of moving on to the final piece of input from panelists, which is coming as a pre-recorded video briefing. So I just urge everyone, if they've got any final questions before we do the Q&A after this, then please post them now. There's been some great questions already coming up in the chat. So as I said, we now have a pre-recorded video briefing on FGMC and religion from our partner, Reyhana Patel, who works for Islamic Relief Canada. She's based in Toronto, and because of the time zone difference, I think it's sort of 4 AM or something there. So we obviously are very grateful for her for pre-recording this for us. So Reyhana is Head of External Relations at Islamic Relief Canada, as I said. She's a former BBC journalist and a former fellow at the Institute for Global Engagement in Washington, DC. She leads the Violence Against Women and Girls portfolio at Islamic Relief Canada, where she focuses on how faith-based approaches can combat violence against women and girls. She led Islamic Relief's seminal report on FGMC in Indonesia, which was published in 2016. So really vital for us to hear her perspectives, given what we've heard from our other panelists today. So let's just give us a moment to start Reyhana's video so we can hear her comments. So in the spirit of partnership, I'm going to hand over to Kesha Mahmood, who is the Programme Officer at Arrow. And she's going to share some of the questions that have already been shared on the chat and hopefully direct them to some of our panelists to answer. Or we've had some questions submitted in advance and we already have answers to some of those that we can share. So over to you, Kesha, and then we'll try and sort out that video. So apologies for that.
Thanks, Ebony. So we've had quite a few questions in the chat, and I noticed that Siva has already answered some of the questions. But let me just start with one question that Siva, maybe you can answer now, and then later I'll just read out the other questions that were asked and Siva's answers. So this question comes from Divya Mukund. She says, a lot of our work on girls' empowerment was around making girls' voices visible and loud. With restrictions on girls' movement during COVID, what new ways of working could be used to keep the spotlight on girls?
Yeah, thanks for the question, Divya. This is, of course, something even the women's movement is like struggling with. But I think that there are many critical things we need to think about when we're talking about girls. One is, of course, the fact that the limitations on movement, but also the reinforcement of gender roles within the household, which increases the care work burden on girls, right? So that's one aspect of it. Two is if the economic, due to the economic fallout of COVID-19 and how it has impacted our economies, we can anticipate, as in all downturns, girls' education will be deprioritized within the household level. They may also, poorer households may resort to child early and forced marriage. So we need to actually show the data where these things have happened in the past and actually ensure that our governments are thinking about it and keep the pressure up that in their policy solutions that are coming up during COVID and post-COVID, that these concerns are still like upmost on the agenda.
Thanks, Siva. There is another interesting question from Kayleen. She says, while a total ban on FGMC seems most desirable, i.e. there are no solid reasons for doing so, how do we then balance this blanket ban against women's bodily autonomy for those who would want it to be done on them?
Is this for me, Kesha?
Yeah, I believe you could answer this, Siva.
Yeah, I think that from the practices that we have seen in Indonesia and Malaysia, this is basically when they are infants. So there's not actually a lot of information. I mean, so this is their consent is never sought, right? So I think that the issue in this region is like framed in that manner.
Great, I'll just read out some questions that Siva has already answered. Okay, for example, there was a question from Divya of Equality Now. She says, when you mention the 1 million of the 4.6 million girls cut every year will be from Asia, does this 1 million figure cover only girls from Indonesia or other Asian countries as well? So Siva says that while most of the numbers come from Indonesia and Malaysia, there are groups practicing it in India, Sri Lanka, and the Maldives. And how we could keep a focus on girls, looking at how the fallout from COVID-19 reinforces care roles on girls and economic uncertainty, girls dropping out from school, increase of child marriage and things like that. This needs to be highlighted as early policy advocacy to governments. Now, let me just move on to another question that was for Ibu Atas. This question comes from Samuel. Samuel says, what cadre of health professionals cut the girls in Indonesia? Where is the cutting done and at what age? Ibu, if you could just quickly address Samuel's question.
Because almost 65% women in Indonesia during delivery helped by midwives. So who perform the female genital circumcision is by the midwives, and started in the year 2000 by the GPs, the physician.
Great, thank you, Ibu.
Yeah. Because if we made a study to see the household, those richer households will ask the doctors to perform the circumcision.
I see. Thanks, Ibu Atas. I just have another question for, this is to Dr. Rashid from Shah Taha. She says, I've always been interested to know how doctors know what to do. Did they learn from the Mak Bidan, or are they going along with their own ideas, hence performing type 1 instead of type 4?
Thank you for the question. I wanted to discuss that earlier, but I ran out of time. Okay, interestingly, what we found out that most of them learned from their senior colleagues. And where did their senior colleagues learn from? It was from religious books and texts, which nothing to do with the medical curriculum, which suggested that they should cut this way or cut that way. And some of these doctors actually went back to the Mak Bidans and learned from them. That is why a lot of the doctors still have this thing about 1 drop of blood. Even when you talk to them, they'll tell you the same thing about 1 drop of blood. When you ask them, where did you get this from? They have got no clue, but they said that, well, it's been done for ages. The other part of the research where we found out, we asked them, what exactly would you want? Well, besides they want MMC, making it clear that it's legal and so on and so forth. The other thing that they wanted was that they wanted the curriculum or a continuous medical education should speak about female genital cutting and how it should be done. But when you ask them who is going to do that, considering that no one has ever done it before, and we have got no evidence on what to do with it. So most of them don't know. They're lost for answers. So basically, it's just that, this is where I said the dangerous thing about it is when they start thinking logically, and it becomes a bit scary when they start thinking that, yeah, what's the point of just cutting the prepuce of the clitoris? The whole idea is if to reduce the so-called libido of the girl when she grows up, so they should cut the the clitoris, which they're doing type 1. What worries me is that if nothing is done, and if this goes on and it becomes completely medicalized, then probably what's going to happen is you're going to have type 2, the next thing. I hope that answers the question.
Thanks, Dr. Rashid. There is just maybe like a follow-up question to that from Samuel. He asks, do you have a program, or is there a program to initiate the do no harm principle, awareness of this principle, through a medical board or any sort of policy?
Okay, especially if you're giving to a medical board, because everything in medicine is evidence-based. So if you're giving to the medical board, it's going to ask you for evidence. What evidence do you have that doctors are doing it in large, as in a big numbers that they're doing it? Yeah. So as I said, from the first study that we did, we found 20%. So we need to do more studies, more qualitative. So if you're going to present it to a medical board, you should have the evidence in hand. So we cannot use data from, say, Africa, which loads of research has been done, and then bring them here, and people turn around and say, well, that's Africa, that's not here. We don't practice type 2, type 3, so this is not the right data to compare. Hence, the first thing that we have to do, I know everybody wants it to be done immediately and quickly, but without first having enough information, having enough data to convince the Malaysian Medical Council and others, is going to be a bit of a challenge. Hence, it is why we need more information. We need a bit more studies, and then using that, convincing the Malaysian Medical Council that we have enough evidence to suggest that they should take action.
Mm-hmm. Thanks, Dr. Rashid. The next question is for either Ermiza or Zainab. Kelly asks, what exactly do you say? Well, basically, she says, what did you say was the subject you were going to talk about when you go down to communities to talk to women? So basically, how do you broach this issue? And there is also another question that asks, how do we ensure that regional messaging and common advocacy goals don't complicate national realities or exacerbate challenges? This is for either Ermiza or Zainab.
Thanks for that question. So when we spoke to women in the course of our study, we actually used we use local terms, basically, that don't actually translate directly from female genital mutilation or cutting, but are actually terms that are culturally used, they're comfortable with, actually reflect, sort of holds within it meanings of a practice that they do that doesn't necessarily have like a negative connotation attached to it. And that's how it's informally referred to here. And maybe it would also help to know that when we reached out to women through the Family Planning Association that commissioned the study, but also through networks, contacts, we indicated right up front what we wanted to talk about. And there was always an opportunity for women and girls to not participate. We went and met and spoke to women at times they chose, at places they chose, and some of them wanted to speak to us alone and some in groups. And there was also a lot of curiosity, because they say, oh, this is not something that people usually talk about. So we were interested and curious as to what you wanted to know. And because it was all women's space, there was also a lot, we found that the conversations, there was a lot of comfort in having the conversations. I hope that answers your question. And I'll leave the second question to Ermiza. Thank you.
On the second question of sort of international advocacy and how that needs to take into account national concerns, I was thinking this has also been an issue at a different level for us, because talking about criminalization in a context where women feel extremely insecure already, Muslim women in particular feel extremely insecure already. And it's really important that national or international advocacy acknowledges and takes account of local concerns and acknowledges that context and presents demands or asks in that textured way, to include some of that nuance as well, so that you understand that it is the demands that are being made acknowledge those contexts or those very specific concerns that women are raising in local context. This should not make us fearful or hold us back in terms of making demands and making asks of our government. I think we have to be bold enough to be able to do those things, but nuanced enough in our language to show the differences, to show that these are the multiple ways in which women also can be affected by this demand, and precautions need to be taken against those repercussions as well. I know it's a fairly vague answer without the specifics in terms of how that can roll out, but I hope that was useful.
Thanks, Ermiza, and thanks, Zainab. I just have one last question, and this is to Lo. This is from Divya. Divya says, criminalizing all forms of FGMC would risk driving underground, a practice that's already shrouded in secrecy. So how would it actually allow for reporting, as both parties, the parents and the practitioners, would be complicit in the act?
Thanks for that question. It's a really, really important and vital topic around criminalisation. In our work at Orchid Project, we do know, particularly from research and programming that we're carrying out with our partners, particularly across Africa and Kenya, for example, that criminalising without proper implementation and commitment to community-based programming can indeed push the practice underground, or lead to cross-border cutting. So where families take girls, for example, to alternative or bordering countries to have the practice undergone. At Orchid Project, we advocate for a holistic, multi-sectoral approach to ending FGC that involves everyone from medical professionals, religious leaders, the justice sector, and vitally the community members themselves. So we recognise that, you know, this is a process towards abandoning FGC that everybody needs to sort of be bought into. Having said that, a law or criminalisation or the lack of a law is seen as vital, both from our consultation results as well as more broadly from international research, in setting a legal norm. So if the practice is legal, as it currently is across all Asian states, we're seeing, particularly from the consultation, that that's seen as quite telling and provides a major sort of structural barrier to actually shifting the social norm itself. So that's sort of, I think, the broader context around criminalisation, that, you know, we would never advocate for a law on its own without proper implementation and commitment to non-judgmental approaches to community programming, community dialogue, which is, again, you know, where the practice is going to end itself. So I hope that gives a little bit more nuanced context to the debate around criminalisation.
Thanks, Lo. And we have some comments in the chat section. Similarly, you know, talking about how, while it's important to have a ban and criminalizing it, it should, of course, come with a very comprehensive plan. And it is, while important, it is also very tricky. Now, Ebony, could I just check if the video of Reyhana is ready?
No, so we are obviously at just a bit over time. So I think what we'll have to do is share that when we share the resources from the webinar with everyone as follow-up. So is that okay? So I'll wrap up now, if that's all right, Kesha?
Yeah, I think we've answered mostly all the questions. And of course, if you have any more questions that we haven't addressed, you can always email Orchid Project or Arrow, and we will get it to the right experts. Thank you.
Thanks so much. So thanks for all the brilliant questions. We've tried to address as many as we can, but we need to wrap up now because we are over time. Thank you to all of our brilliant speakers. Thank you to all of you for joining us from various parts of the world. We're really thrilled with the interest and commitment to working together on this issue. So thank you again. I wanted to just sort of say that we hope that this has provided some much needed food for thought and a starting place for a number of vital discussions on this practice across the Asia region. But this is obviously just the beginning. We need to stay connected and focus on our mission of raising the profile of this issue, but critically holding governments and others involved in maintaining the practice to account for commitments to end it. So we have commitments through the Sustainable Development Goals, we have commitments via various international human rights treaties such as CEDAW or the CRC, which are not being upheld. So the next steps are we're actively seeking partnerships, collaborations and funding to support the amazing work being done on the ground, to strengthen the evidence base, to challenge the norms that underpin the practice. So please stay in touch and we'll follow up and let us know if you want to stay involved in the network or obviously join the network. We'll provide a registration link for that later on. So we look forward to working with you in partnership to end this practice for all women and girls across Asia. And we'll send a follow-up email with a recording of the webinar to all those who've registered, alongside a list of resources and research by our panelists, which I know that you've all been interested in hearing about. So thank you so much for joining us. Stay safe and stay well. Thanks very much. Bye-bye.